Bismillahirrahmanirrahim. This station is about abnormal cervical smear in pregnancy. This is a structured discussion task. You are fourth year resident and you are about to see a patient, Mrs. Samaya, who is 35 years age in the antenatal clinic. She had a routine cervical smear and then she had an unplanned pregnancy. Your task is to read the cervical cytology result. Then your consultant will ask you some questions about this case before you see Mrs. Samaya to put the proper plan for her management. And your task is to explain the results of the smear, formulate a management plan, describe how you will tell the patient about the result, and answer the examiner question. This is a smear report. Mrs. Samaya MR number is 235 by 25. And the result shows there are atypical squamous cells and high-grade dyskaryosis. And recommendations are that patient should go for colposcopy and HPV risk assessment. So the first question is that what other information you need to know about her. So in this case, you will ask about the current pregnancy and you will ask about any bleeding, that is intermenstrual bleeding, postcoital bleeding, any complaint of abnormal discharge, any history of metastatic symptoms like loss of appetite, loss of weight, or any urinary symptoms. Was she having regular periods? Was she using any contraception? What about the previous smear results? Any history of sexually transmitted infection? Her partner history is important. Her previous obstetrical history is very important, and you will ask about the previous medical and surgical history and rule out the drug allergy. Then, what are the guidelines about the cervical screening during pregnancy? Guidelines say that if an individual has been called for routine screening and they are pregnant, the test should be deferred. So, routine screening you can defer during the pregnancy. And the second point, an individual referred with an abnormal screening test. She should have colposcopy in late first or early second trimester unless there is a clinical contraindication. So if the smear result is abnormal, you can plan the colposcopy in the late first trimester or the early second trimester. And the next is if a previous colposcopy was abnormal and the individual becomes pregnant, then the colposcopy should not be delayed. Okay. If the previous colposcopy was abnormal, so the follow-up colposcopy, it should not be delayed. The next is if a pregnant individual requires colposcopy or a screening sample after treatment or follow-up after CIN1. This is important. This is not the invasive disease like CIN2 or 3, not the advanced disease. This is CIN1 only. Then their assessment may be delayed until after delivery. Okay. Then if a repeat screening sample is due and the individual has missed or defaulted their appointment prior to pregnancy, then a screening sample or colposcopy during pregnancy can be considered. Okay. So if already the patient has missed the appointment or she is defaulted, she has not attended the appointment, then you can consider the screening or the colposcopy during the pregnancy. So if we summarize all these points, it means that routine screening can be deferred 3 months after the pregnancy. But the abnormal screening management, it depends on grading. If she is having low grade disease, like she is having CIN1 only, then we will do the HPV triage. And if she is high risk HPV triage is negative, then we will do the colposcopy after delivery. But if high risk HPV is positive, then we will do colposcopy during the pregnancy. That is in the late first or the early second trimester. But if she is having high grade lesion, then we will do the colposcopy in late first or the early second trimester. And if she is having previous abnormal colposcopy, then colposcopy should not be delayed. So this is the summary of the points which we have discussed before. Then what are the recommendations regarding colposcopy during pregnancy? These recommendations say that an individual who meets the criteria for colposcopy should be examined in the colposcopy clinic even if they are pregnant. So she should be examined by the expert colposcopy specialist. And what's the primary aim of colposcopic examination? The primary aim is to exclude the invasive disease and to defer the biopsy or treatment until the individual has delivered. Okay, so we have to exclude the invasive disease by doing the colposcopy, and we can defer the treatment if uh, the invasion is not suspected. And individuals seen in early pregnancy, they may require a further assessment in the late second trimester. Excision is usually reserved for individual where we are suspecting a high-grade disease or the cancer. And if an individual declines the treatment in early pregnancy, they should be seen for postpartum colposcopy. Okay. So if we summarize these points, then we can say then that if CIN1 or less is suspected, then individual should be managed as per the screening algorithm as that of non-pregnant. But if CIN2 or 3 is suspected, then repeat colposcopy at the end of second trimester. And if the pregnancy has already advanced beyond 28 weeks, then we will repeat 3 months after the delivery. Okay. So if the patient is in the is up to the second trimester, we will repeat at the end of the second trimester. But if the pregnancy is beyond second trimester, then we will do after delivery, 3 months after delivery. But if the invasive disease is suspected, then a biopsy adequate to make the diagnosis is essential. Okay. And studies show that excisional treatment, they are safe in pregnancy in the first and the second trimester, although there is a risk of hemorrhage. Therefore, such biopsies should be taken only where the appropriate facilities to deal with the hemorrhage they are available. And punch biopsies suggesting CIN or only, they cannot reliably exclude the invasion. So we have to do the excisional treatment, and in which there is a risk of hemorrhage. Excisional treatment is less. And the risk of flats during pregnancy can be bleeding, infection, there can be cervical shortening and insufficiency. There is risk of rupture of membranes and preterm labor. And during the labor, patient can have cervical dystocia and traumatic postpartum hemorrhage. Therefore, it should be done in a place where appropriate facilities and to intervene are available in case of any emergency. So, the question is that how you are going to tell the patient about the report and the further plan. So always you will confirm the patient name and the hospital number at the result. And you can ask the patient that what she knows about the result. Then you will give the warning shot that are you alone or do you call someone with you? And then you will tell her that I am so sorry that I don't have a good news. We have some concerns regarding the results of the smear test, which is a sample that is taken from the neck of your womb. And there are some changes in the cells of the neck of the womb. But these changes are at a stage before they become cancerous. Okay. And these changes, they can be mild, they can be severe. As your smear is abnormal with severe changes. What was the smear report? It was high-grade dyskeriosis. So there are severe changes. So you need to be referred for an investigation that is known as colposcopy. That is a more detailed look at the neck of your womb. And colposcopy, it will not harm your baby. It will provide valuable and reassuring information that will help us in putting the best plan for your treatment. And we will tell her that according to the results of the colposcopy, group of specialists called MDT, they will decide either to continue with the follow-up and then to repeat the test 3 months after the delivery, or to go for surgery to take a biopsy or a piece from the neck of your womb for examination. So we will tell that these are the severe changes and we will refer you for the colposcopy, that is a camera test from the neck of your womb. And according to the colposcopy findings, we will plan the treatment. We can continue the follow-up and then we'll repeat the test 3 months after the delivery, or we can go for surgery. We will take a piece of tissue from the neck of your womb for examination, and you are more likely to bleed if we take a biopsy or treatment when you are pregnant. Okay, we will tell the risk as well. And along with this, we will give a patient information leaflet and we will fix our appointment with the consultant. So in this way, we will tell the options of treatment to the patient. Okay. So if you have any question, you can ask me. Thank you very much.